everybody, and welcome to a special continuation of what is a three-part episodes mini-series, excuse me, of the nursing profession. Now, if you recall, 2 weeks ago, right here on Frank About Health, Phyllis, Lynn, and myself were giving an overview of the nursing profession and how it differentiated between a nurse with a PhD, such as Phyllis, and a nurse practitioner, which has been forever an evolving profession because the caregiver or the caregiving continues even beyond the initial trauma the patient endures. And the nurse practitioner has the value to become almost part of their family in recovery. And as such, they do have a very viable role in the health profession, but we have a lot of continued social misunderstanding, which is why it was important during that show on the 19th of February that we agreed to reconvene today, the 26th of February, and next week, the 5th of March, for a two-part, what I call to action to bring about the awareness, the understanding, and the importance of the nurse, not only the nursing profession, but the nurse practitioner. And so today, being that we are under a three-segment format, I think it's beautiful where I will basically overview the show in segment one. Phyllis will ask all of the necessary questions that we need to learn to Lynn, and I will chime in any questions that may come up on my part. And then Lynn will definitely be the segue, not just for the end of this particular episode, for all the necessary preparation for next week's show. So that being said, I will issue my typical disclaimer. These are not the views of talkradio.nyc or of Frank About Health, but they are very important views of the nursing profession within the health system. And therefore, there may be disagreement, but I'm here to advocate for what is important for your patient, if you are a nurse yourself, or doctor for that matter, for your family, for anyone that really wants to understand how valuable nurses and nurse practitioners are. And therefore, I want to welcome you both back. Phyllis, especially you. You are truly my anchor when it comes to dealing with what is a sensitive topic. And you know, I always have my own self concerns because I'm not licensed and I'm not a medical professional and I don't want to say anything that violates any HIPAA laws or whatever. And you help me regulate all of that. So thank you for that. And Lynn, I welcome you back. As Phyllis said, this is your show, as will next week. And we are looking forward to learn all about the history, the licensure, the financing, and pretty much everything that is of definite concern considering our current administration. But enough said on that topic. So that being said, I just want to welcome you both back and start going through, let's start with the history of the nurse practitioner.
Well, Frank, thank you. As always, you've always been very supportive in advocating for professional nurses who are practiced at any level. And,
Yes.
I just want to say a collective thank you for that and for giving us this forum to be able to raise awareness about, how nursing has developed literally over the last 60 years and all the strides that we have made and how that benefits the greater public at large. We talked about the history of nursing in episode 1 2 weeks ago, but Lynn, let me jump in. You're on mute. I just want to bring that to your attention. Um, Let me just start off with saying, please, let's start at the very beginning. What is the difference between a registered nurse, an advanced care practitioner as yourself, a nurse practitioner, all right, and a physician? And just so that the general public and Frank's listeners are aware of this, because I think there's a lot of confusion and we're still not sure, especially when so many of our nurse practitioners are prepared at the doctorate level and may have a doctor or a credential after their name and even before their name. It lends to confusion. So we really want you to shed a lot of clarifying light on that.
Well, so it's great to be back with both of you this evening to talk about the nurse practitioner profession, near and dear to my heart. And the nurse practitioner role actually started out of a need for helping to respond to provider shortages, looking at public health because nurses go out into the communities where they serve. And there were a lot of things that were happening in healthcare that our role was expanding. So that's kind of the background for the development of the advanced practice role. So nurse practitioners start out as RNs. We go to school, become basic trained as nurses. We get our experience, and then we go back to get our advanced graduate level training. So we can diagnose, we can treat, we can prescribe medications, order testing, evaluate, really provide a lot of care to patients who have many common illnesses and chronic diseases. And we're all in different settings as well. We can be in the patient's home, we can be in hospitals, we can be out in the community. So there's a lot of places where nurse practitioners will provide that care. We do focus a little bit differently than physicians because the physicians focus on the medical model of care delivery, which really focuses on the disease. Nurse practitioners are trained in the nursing model, which is a more holistic approach to healthcare. So we look at the patient in the center and what are the things that are going on around that patient that that diagnosis may be affecting. So if somebody has, for example, asthma, is a parent in the house smoking. So we would have to do some education for the parent so that they could understand that the smoking can impact the asthma. So it's not just looking at that person with asthma, but how and all the things that are around it that might be affecting getting that patient to the optimum level of wellness.
As I remember, when we started talking about advanced care practitioners, prior to that, we had master's degree in education. You might have a master's degree in nursing, period, or a master's degree in nursing leadership administration. But I think the first one that I was aware of that was clinical was the nurse anesthetist. Do you
Yes.
remember back then? Can you speak about that and then how it kind of morphed into the body of nursing that you represent here today, but also went into different specialties, pediatrics, psychiatry, cardiology, et cetera?
Mhm. So the certified registered nurse anesthetists were really the first, and they were the boots on the ground in the battlefield. So their roots are deep. And they actually were the first anesthesiologists, even before the physicians. That role didn't develop until 1927. So the CRNA role actually predates the physician's role in that. And they provide anesthesia in the battlefield, but they're also now out in the community providing care in hospitals. I think most of the anesthesia care that's given in a lot of the facilities is directed by the certified registered nurse anesthetists. They have banded together and they are really mobilizing the opportunities for the advanced practice role. And then we had the clinical nurse specialists that happened. They started in the 50s and they primarily were psychiatric and med surg specialists. So they were in the hospitals and they were doing a lot of the leadership and education. They used to call clinical ladders that nurses could escalate into. But they were starting to advance the clinical knowledge, the clinical expertise that nurses had. And then they, again, like I say, were mostly in the hospital setting. Registered nurses, the role of the nurse practitioner was really developed in 1965. That's when Dr. Loretta Ford worked with Dr. Henry Silver, and they developed the first pediatric nurse practitioner program out of the University of Colorado. And this was really developed because she was going out into the community and providing care to children, pretty much. And these were kids that weren't getting care or access to care. So she would go out and service that community. She would be in underserved and underinsured and communities where they're healthcare deserts, basically. Does that sound familiar? I think a lot of our areas today are
It does. And I really want you to speak about that because, people are like, well, we have physicians. Why would we even need the role of a nurse practitioner? But, when we went through COVID-19, when we were all responding to all of that, I mean, the what bubbled up to that was a real problem with access to healthcare across the board, across the whole country. Speak a little bit on how the nurse practitioner fills that role.
what I find is a lot of the nurse practitioners are seeing problems within the community or needs that are not met, and they're the ones that are going out and creating the solutions. So if there's a need in a particular community, for example, if diabetes is primarily a big concern with children, for example, a nurse practitioner may go into the community and establish a practice and pretty much try to take care of those children and provide that holistic care, because it's not just getting their diabetes diagnosed, but it's how do they manage it.
Right.
It's education, it's medication, it's diet, it's exercise, it's educating the parents who now have to take care of them. So there's a lot that goes into the development of that type of care delivery, which is different. And I think that's one thing that I appreciate often when I see patients who have never seen a nurse practitioner before. They'll have a visit and they'll say, "Wow, you really listened to me."
Right.
And that was something different. I've never experienced that before.
Mhm.
And that's when I think people start to understand the true value that the nurse practitioner role brings to healthcare.
Right. Right.
During COVID-19, I can't say enough about the NP role in really providing care to, I mean, everyone.
Yes.
We saw people surging to, emergency departments and to any place where they could receive care in numbers never experienced before. And certainly there were not enough physicians to go around. So could you just speak a little bit to the COVID-19 response, and then I know that there was some broadening of regulations to accommodate the need that was the patient care that was needed during COVID-19. And if I understand correctly, those have been rolled back. And where does that leave us?
Yes, COVID-19 was a challenge, and there were hotspots within the country. So Washington State and New York, for example, had the greatest need initially. And the only way we could mobilize the workforce is to reduce the barriers to licensure and practice. So all the barriers that we had regarding prescribing, supervision, not supervision, collaboration, and all of that licensure were waived during the pandemic, the public health emergency. So we were able to go where the needs were greatest, whether it was going to a hospital or elsewhere. That was great. And then during that 2.5 year period, we were providing care all over the place.
Oh,
And then when the public health emergency ended, all those barriers came back. And that was a disservice, I think, because
Yes, it
we
was.
were able to provide all this wonderful care out there. There was not, I don't recall seeing anything that there were any egregious, lack of care or
Yeah.
situations where, nurse practitioners were not providing good quality care. We were actually the ones that were running to the fires, so to speak.
Yes.
Yeah.
We were the ones that were taking care of those patients. So, to go back and put the genie in the bottle again is really a disservice to a lot of folks who really do desperately need care. And we're finding that the number of nurse practitioners is increasing, but the number of primary care physicians is decreasing.
It's
And even
decreasing.
if they, try to increase the number of slots for medical schools, people are just not picking that. And even if they do pick internal medicine or family medicine, it's not going to solve the shortage that currently exists. So,
Yes, I agree. I know that you took the words out of my mouth when I was coaching a lot of people while they were in the middle of their COVID-19 response, trying to help them decompress. I just kept reminding them, don't let them try to put this genie back in the bottle, because you're different than you were prior to COVID-19. That was such a transformative experience. Please
Absolutely.
remind Frank's listeners how many hours of clinical practice it takes for you to be able to sit for your license and your certification exams.
So when we are trained, we actually start out as nurses. So we go to nursing school. We get clinical experiences through that. And I don't have my information in front of me exactly
So
with
for the
that.
BSN program,
Yeah, I think it was
so
750 hours.
I think that's about right. Yeah.
And then another 750 hours. It's about
Mhm.
4,000 hours if you're
Mhm.
doing full time.
Right.
experience because you do have to get the education and training, and then you have to
Right.
do the clinical hours that allow you
Right.
to practice. And, once then you sit for your certification exam
Right.
in the specialty area that you're in. So we're certified as a registered nurse, we get licensed, and that allows us to be RNs. But then when
Mhm.
you go to school as a nurse practitioner, you're in a population focused curriculum. So
Mhm.
your pediatric, your family nurse practitioner, your adult gerontology nurse practitioner, your psych mental health nurse practitioner, your women's health nurse practitioner,
Mhm.
your acute care nurse practitioner.
Right.
I got them
And
all.
as I understand it, most hospitals and healthcare organizations require you to have passed your certification exam
Yes.
before they will hire you. It's not as though, okay, I graduated the program, I did my hours, I don't have to validate competency and knowledge. There's an absolute competency and knowledge pathway prior to being employed.
Absolutely. And throughout the nurse practitioner's training, it is competency based because you can't advance unless you meet the competency
Mhm.
requirements. So, so all along the way, there are checks and balances that will happen.
Now,
Okay.
before we take our first break, I have two questions, one for you, Phyllis, and one for you, Lynn. Phyllis, I'll start with you. When we first met around the time of COVID, I think Omicron, it was around that time when we
Hmm.
first met and we started co-hosting together. You were big at that time, as I'm sure you still are, on caregiving. What I've learned from Lynn's discussion is that caregiving itself, like how I became one for my cousin and my father, that became an offshoot of the essential worker, where they were allowing families to do it and get paid for it. And yet it was differentiated from the nurse practitioner because they were not a professional, they were a personal family member. So, can you answer what is the correlation between the nurse practitioner and the traditional caregiver?
So if you're talking about a traditional caregiver, are you talking about it in terms or the context of a family caregiver?
Family caregiver, PCA, any of those individuals.
Okay,
They're
well,
licensed to do it.
so, a home health aide or a
Right.
personal care assistant or associate, okay, they're not licensed. They take fundamental training.
Yes.
They're trained in safety. They're trained in something called activities of daily living,
Yes.
which is, mobility, toileting, eating, uh, uh, moving, transportation, the things of that
Yes.
nature, and they're trained in safety issues. So they're trained in, making sure the skin doesn't break down, making sure people turn in position, making sure they're not staying so immobile that they are potentially have a risk for pneumonia or anything of that nature. They
Yes.
cannot administer medications. So a family
I
member
see.
has to put out the medications, or what they can do is remind the client, the person that they are caring for, Mary, it's time for your medications, and then Mary takes her own medications. Okay, so they
Understood.
they cannot
Understood.
do that. All right. Um, it's some of their clients might be in hospital beds, some of them will just be mobile in their own homes. So it really does depend, on what's going on and how many hours. Long ago, before we had the economic decline of 2007, fairly easy to get care 24/7,
Yes.
because the care was there and the funding was there. But I can remember after 2007 and families asking for 7 day a week, 12-hour care for their family members. They were very upset and thinking, our discharge planners were not doing their jobs because we couldn't provide that for them. It was just that the care was not there to be funded to provide. What you would qualify for after 2007 was
Right.
about 4 hours of care, 3 days a week at
Mm.
max. Everything else you would have to pay out of pocket.
Mm.
Thus, the family caregiver became a vital member of the team. Now that
Yes.
supplemental care, if they could not um, financially afford to bring in supplemental care, they would have to provide caregiver around the clock. And remember when we talked about Share the Care, that was an outgrowth of that. That book, Share the Care, was a training manual, if you will, on how to put care circles around people to supplement the care of the people that were in the community, to try to
Absolutely.
keep them in the community so that they didn't decline and have to be hospitalized, but also to take the burden of family caregiving off that family caregiver, or and spread it around a little bit so that everybody was doing the right thing, staying healthy, but also we were focused on mental health needs and human needs of
Yes.
having to take care of that.
All right. And so
Very,
now we're,
very,
go ahead.
go
I'm
ahead.
sorry.
No, very, very different than licensed people coming into your home, such as a visiting nurse or
Right.
a nurse practitioner. Very different, two different things altogether.
You know what I find, I don't know if you call it a shame or a personal disappointment, is that obviously it took COVID to actually give the benefits that patients needed, including family support and stuff like that. And then, like you said earlier, Lynn, the genie went back in the bottle and just completely disrupted what was actually a positive outgrowth of the
Mhm.
pandemic. And I think what I look forward to in the next two segments of this episode is how this call to action campaign, or whatever you want to refer to it is actually us, like what I always say on every episode, owning our healthcare and owning our support and advocating locally, especially when the disruption continues at the top.
Mhm.
I wasn't going to ask you a specific question, Lynn, and we are about to take our break. I was just going to let you know that during our break, I want to, show your site and everything else where people can find out information about your network, but it'll give you time to go look for whatever you wanted to show us, because we have sharing privileges, including the licensure or even the hours of clinical training. If you want to flip the screen and show a little slide thing, you have the permission to do that after we return on our next segment. Okay?
Okay.
Okay.
All right, so everybody, please stay tuned right here. This is a very important show about nursing practitioners, and you already got the history. Now you're going to know about the actual development and practice and eventual support that we all need. All right, stay tuned.
Are you a spiritual seeker? Are you interested in expanded states of reality? I'm Sam Leibowitz, your conscious consultant, and on my show, The Conscious Consultant Hour, Awakening Humanity, we will dive into these topics with authors, teachers, researchers, and guides. Tune in at our new time, Wednesdays at 12 noon Eastern Time. That's The Conscious Consultant Hour, Wednesdays, 12 noon Eastern on talkradio.nyc.
You're listening to Talk Radio NYC. Uplift, educate, empower.
Okay, everybody, and welcome back. This segment is going to be the heavy Q&A. If anyone out there is watching us live right now on YouTube, LinkedIn, or Facebook, feel free to ask any questions of either Phyllis or Lynn. You could ask me some, but I'm going to end up deferring to the actual professionals. So either way, we just want to have as much engagement on this very important topic. So I think, Phyllis, you were going to kind of lead off all the kinds of questions that affect the
Mhm.
education, the licensure, and
Right.
all of the necessary education components that's important to understand.
So,
Mhm.
Lynn, you were sharing in the last segment how some of the feedback that you get from patients and clients and family members. I had the luxury of having a nurse practitioner in my parents' primary care um, office. And she was just amazing. And she was of Irish descent, so she got my Irish parents, which was a lovely added bonus because you can be a little nutsy Fagin, as they say. And she could translate through all of it. The situation was that they felt less rushed with the nurse practitioner than they did with their physician. And if they were just going for a well check and other things, the nurse practitioner made much more sense. And she was able to, suggest maybe physical therapy or different things. Of course, they were not prescribing as such without consultation. I want people to really understand. I just want you to speak to that as well, is that everything is done in consultation so that, if your MD is prescribing one thing and has a regime and your nurse practitioner steps in, you're not pulling in two different directions. Could you just speak to the little yin and yang there is between physicians and nurse practitioners? You're on mute, Lynn.
That's right.
There we go. Thank you for that question. There is a lot of overlap in what nurse practitioners and physicians do for work. Nobody practices in a vacuum or a silo. We all have our lanes that we stay in. But certainly there are situations that come up when we see a patient and we may determine that we might need to make a medication change. And if that medication was prescribed by a cardiologist, for example, I may get on the phone and have a conversation with them and say, hey, this is what's going on with the patient. I'm concerned that the medication that they're on could be a problem, and we work together to solve that problem. The same thing with a radiologist. If I order an MRI and imaging and there's a tumor there or a spot that needs to be assessed, I might call the radiologist and say, is this something that we could, is it amenable to do a ultrasound guided biopsy, or is it something that the surgeon needs to be consulted? So there's a lot of different connections. Pharmacists are our friends. I love to consult with the pharmacists on medication management with the patients. So we're not afraid to consult with the people that are going to help us. I always often say to my students when I train them, I said, know your resources. Know where you can go to get the answers to your questions, because we can't know everything.
Right. And that's not really to infer that you are not trained well enough. That is to infer that you are wise enough to understand that bringing in other subject matter experts, so to speak, only raises the level of care, but it also increases the safety net for that patient. I'm sure you have said to your patients, as I have in the emergency department, job one with medication is use one pharmacy and only one pharmacy. I don't care if something's on sale down the street or whatever, pay the extra $5 or whatever it is, but that one pharmacy will keep you safe and sound with your medications, because they will be able to have that discussion with the licensed practitioner who ordered, or prescribed the medication, because often they're not aware of, physicians and NPs may not be aware of things being at the maximum dosage or having interactions or some other thing that you are on that is on your record in the pharmacy, but you neglected or forgot to share. One of the things I loved about having our NP with our parents was that, I would write out a card of questions and remind my parents, take the card with the questions, to the office. And 9 times out of 10, the end of this story, right? The card was on the kitchen table that never went to the office. So I did, the questions, I wasn't sure of what they asked, but more importantly, I wasn't sure of the answers. I just found it so much easier to contact and get a hold of the NP, who then would, of course I had HIPAA rights, would then walk me through, for the 5 or 10 minutes, walk me through what that, a summary of the visit and what the plan was and how we're going to follow up. And just to make sure that I was included or my sister was included, so we kept mom and dad safe. But I can go on and on about how I really felt that the depth and breadth of quality that the nurse practitioner brought to my own parents' care was excellent and invaluable. Can you talk a little bit about what we're seeing as far as the quality of care the NPs are providing? We have 20 years of research now to kind of validate the role and the evidence-based practice that they are providing.
Yes, absolutely. I did want to go back to, though, the conversation we were having about not practicing in a silo. I
Mhm.
can tell you that there are many times when, because I was a GI nurse practitioner and I basically ran the hepatitis C clinic in our practice, that physicians often called me for
Mhm.
advice when it came
Mhm.
to that. So it's a
Mhm.
reciprocal relationship. So,
Yeah.
there's times when, you go to the person that's going to help you the most. But going back to the studies, there's been peer review literature throughout the decades that show that we're quality providers. We provide safe, quality, cost-effective care. We have high patient satisfaction. And again, I think that speaks to the ability of us to listen to our patients and
Mhm.
provide that tailored care that
Mhm.
they expect. And then we're going to areas where the populations are underserved to provide the quality care to folks in those types of communities. So there's been a lot of research that has been done. There was just a Cochrane report issued just a couple days ago that I received saying that in hospitals, the care between nurses and physicians were equal.
Mhm.
So there was really no difference. And if not, there was also a slight improvement in the quality and patient satisfaction
Mhm.
when nurses took care of the patients.
Mhm.
So um, the evidence is there.
The evidence is there. It truly is. What else can you share about how the nurse practitioner, fills the gap for needs? There's some very, very strong concerns about maternal health here in this country, as there should be for the country that we are. Our life expectancy for, and quality of maternal child, or especially the mother, is embarrassing, to say the least. So, can you speak a little bit about that, and how they serve the gap of perhaps underserved communities?
Definitely, again, the nurse practitioners look at the communities that they serve and how can they best meet the needs. One of our nurse practitioners takes care of the Chen population in her
Mhm.
area because they can identify with her,
Mhm.
and they trust her, so they'll go to her for that care.
Mhm.
Substance abuse is a big area in addiction, where we're
Mhm.
finding a lot of nurse practitioners affecting care, depression and anxiety, mental health issues, and they're going to where the needs are. The kids, a lot of issues with children, behavioral issues, depression, anxiety, drug use. Those are all areas where nurse practitioners will be tending to gravitate to. The other thing is the elderly. A lot of the elderly cannot get out of their homes to go to seek care, and we can go to them to provide
Mhm.
that care, which I think is another option that people don't realize. We go to where the patient's needs are. Now, a lot of nurse practitioners are also working with employers to keep people at work.
Mhm.
So instead of trying to take time off and going to an appointment, we can go to where they are and provide the
Mhm.
care on site, which it saves the economy. I think that's the other thing. There's such an economic value that nurse practitioners can bring to communities because we're creating small businesses. We're
Mhm.
employing
Right.
people within our communities. We're adding to the economics of the communities that we serve. So there's a
And
lot.
primary care will always be less expensive than emergency care. That will never go away. I want you
Exactly.
to talk a little bit about, or at least help raise awareness for our parents who may not realize that that school nurse is a nurse practitioner. It's not just, the school nurse back in my day, they checked our vision and, called mom if we were sick at school. And, I really never fully appreciated their role, but it was quite narrow in scope. Given the fact that most of our children with multiple comorbidities are mainstreamed.
Mhm.
Could you speak about the role of the school nurse and how the NP fits into that?
A lot of nurses are in the school system, and then nurse practitioners often will be seen in school-based health clinics that are cropping up because, again, access to care is a huge problem.
Right.
And we used to have health education in some of these programs within the schools that now the nurse and the nurse practitioner will be taking care of some of that. Also, the children are coming in with special needs. Many
Hmm.
are on medications that they have to take during the school day, or
Feeding
they might
tubes.
Yeah, physical
Central lines.
challenges.
Mhm.
Yeah, absolutely. So there's a lot of opportunities for NPs to be in these roles and to provide that care so that these kids can get the education that they need.
Mhm.
And the parents should have at least comfort knowing that there is somebody, a medical professional within the school system that can help if there's something that happens with their child during the day, that there will be somebody there to care.
I think it probably provides a great deal of comfort to, it would for me, if my child had complex medical needs and was being mainstreamed in the school, I would want to know that someone could respond to those needs, whether it was with an EpiPen, a phone call, 911, suctioning, giving tube feeding, making sure skin isn't breaking down, throughout the day. The stories that I'm hearing from my colleagues who are nurse practitioners and school-based nurses is that it's very community oriented, but it's very medically surgical oriented. You have to have those basic fundamental medical surgical skills on top of your ability to assess those things at an NP level and interact safely. I
And
think it's pretty amazing.
it
I do
used to
have, I
be,
do.
oh, go
No,
ahead,
I was
Frank.
just going to say that based on all of what I'm hearing right now about school nurses and things like that, that must be that the environment in itself can either frustrate or free up what the nurse practitioner role is, depending on what the educational institution is or healthcare institution is or whatever. Is that an issue of the state that the system is operating under, or is it just an institutional level?
Um,
It can be both.
It's
It can
it
be
is
both.
both. It's gonna come under whether your school system allows nurse practitioners
Uh,
to practice, and who does that nurse practitioner report to? You could speak to that more, I think, Lynn, than I, but I do know that there is a bit of frustration that most of the nurses in the school system still have to report up to the principal. And they may have phone contact with a physician or EMS base
Mhm.
to bounce things off of them, but there's still that non-clinical person in the loop. And that's
mm,
not to say it's not, it's not safe or anything, but this is a non-clinical person who might be weighing in on, do we send Johnny home or do we not send Johnny home? And motivations might be very different. So, there's always something, this work, even though it's what, 20, 30 years old now, it's still pioneer work,
mm,
in the sense that we are still working we're still, here we are in, 2026, talking about a profession that has been around for 30 plus years, and we're still trying to raise awareness as to how qualified they are, the clinical practice hours that are maintained, the certification that has to happen and and the value of the role 30
mm.
years later because people are still not quite as informed as they could or should be, and still have that question is, well, if I go to the nurse practitioners, do I still have to go to the doctor, or what's the difference between an RN and an NP, and they still have those questions, which is why this program is so very valuable.
And,
Absolutely, absolutely.
and I was going to also say that technology and medicine and medical care and nursing care all across the board has definitely extended out to the community. It used to be a lot of these folks were treated in the hospital, but now
Mhm.
because of technology and the advances in healthcare, we're able to care for these folks in the communities, which is
Right.
quite different
Yeah.
Mm.
than it used to be. So you have to have a certain skill set in order to take care of folks.
So, Lynn, you touched upon something I wanted to talk about. Could you just talk about the NP role in telehealth?
So the
That's a good
MP role in,
question.
yeah, so telehealth actually transformed healthcare during COVID, which was amazing. And practices that could pivot to telehealth actually were able to care for patients
Mhm.
more expeditiously. I know our practice was able to transition to telehealth quite easily. But it was interesting. I had a conversation with one of my patients who was elderly, and I was the first person that she spoke with in 3 months. She hadn't had any human contact with anybody other than our Zoom call that we had, our
Wow.
telehealth visit. And it really caused her to be depressed.
Mhm.
And, I said to her, I'm going to call you next month and I'm going to make sure that, you're okay. And after COVID ended and I saw her in the office, she gave me the biggest hug and she said, "You have no idea what a lifeline you were
Lifeline, right.
during COVID." And, that's the kind of thing that these telehealth visits can really help. And you can manage crises a lot better when you can get to the people right away. And
Right.
telehealth does provide that. If you have to wait to get to an office visit, you might be waiting quite a while, and then now you're going to go to the ER or an urgent care, which is, higher level expensive care that could be provided via a telehealth visit.
Back in the time in my profession where I was a chief nursing officer in subacute care and long-term care physicians, I relied so heavily on my nurse practitioners. They were on site during the whole time. The physicians might come in for a few hours and may have office hours for here, and that was understandable. There's no judgment around that. It really just was, if I need you, I need you now. And having the nurse practitioners there. So we would have our own nurse practitioner who was essentially our wound care person, not just for pressure ulcers, but for surgical sites and central lines and different things. But we would also work very closely with the nurse practitioners that were the providers for insurance for the the Medicare programs that they came in. So they were their own providers for different payer sources. But it was just really not just convenient, but a joy to work with someone who had such command over the knowledge of the patients and really knew what was going on, and we could really collaborate and work well together to keep that patient safe and give the best possible care. It was truly,
Yes.
Wonderful.
We are about to take our final break, and when we return, we're going to hear a lot about what I keep calling this call to action, because it's a quote that I'm going to actually read back from Lynn. How we can and need to be the change that healthcare needs. That's exactly how we're going to close this episode of Frank About Health, but lead in to next week's show where we really continue on and get more down to the bare facts of the challenges that are ongoing with the nursing practitioner field, and how we can somehow combat them or get additional resources, so forth and so on. So please stay tuned. We'll be back in a few. On Frank About Health, we're not just talking healthcare. We're managing disruption and innovation. Over the last 4 years, I've taken you from epilepsy and COVID to mental health, caregiving, and now the front lines of healthcare transformation. Stay tuned for a healthier future as we bring on the innovators, professionals, storytellers, and advocates who show you how to own your healthcare every Thursday at 5 p.m. Eastern Time on talkradio.nyc.
You're listening to Talk Radio NYC at www.talkradio.nyc. Now broadcasting 24 hours a day.
Hey everybody, and welcome back. Now, I'm looking forward to observe exactly, Lynn, how you want to approach what you want everyone out there who's watching the show right now to pay attention to over the next few days. And I know we've already touched upon it, but I would like you to take over this segment along with Phyllis and really reach out to everybody that will hopefully have a response by the time we reconvene next week.
Lynn, let's lead up to that, okay? The first thing I think people need to understand is an NP in New York is different than an NP in New Jersey. Do you want to talk about that just a little bit?
Sure. Actually, going back to COVID, talking about those barriers that were reduced or eliminated during that period, a lot of those were regulatory barriers that are state specific. So, and put that in perspective, if you are a physician, you're licensed in any state. You can do the same thing in any state. Nurse practitioner practice varies by the state. So there may be full practice authority, reduced practice, or restricted practice. And that could be either a collaborative agreement that's needed with a physician, there might be a joint board between a physician board and a nursing board. There might be prescription requirements where there's co-signature or chart review or something like that. So every state has their own rules.
I think it was hinted in, I want to say Healthy People 2030, that one of the goals, if I remember correctly, was to try to standardize what the NP, the scope of practice for the NP
Right.
for all 50 states. And you know, one of the, the catchphrases in healthcare, of course, is continuity of care. And I can feel that, if the NP practice in New York is different than, let's say, it's in Florida, and you have snowbirds used to working
Mhm.
with NPs in New York, they go to Florida and it's totally different.
Yes.
There's a gap there and a disappointment. I know you have an education grid that, would you want to take a minute and share that with us and just walk us through it again? Because again, really important for Frank's listeners to understand the amount of preparation that takes place.
All right. So this is the education grid
There you go.
for APRN training. I don't know, can you see that?
We
Yes.
can.
Okay. So when you're looking at the BSN, which is
Just make that a tad smaller so it fits on the screen altogether.
Sure.
Maybe about 120 might do it. There you go.
How's that?
Great.
Okay. So if you're talking about a bachelor's in nursing, that is your basic RN entry level at 4 years. There's 750 clinical hours that somebody needs to attain. And then you're sit for your NCLEX or your certification exam. Then you're licensed as a registered nurse. When you go on to get your master's, that is your nurse practitioner. That's another 750 additional clinical hours that you have to have. You also have to meet core competencies. So you have to be able to show that you can do the work before you can advance to the next level. And then you get your national certification that you sit for the exam that prepares you to go off on your own as a nurse practitioner. So the master's is a 2-year.
Okay. Now,
And then so you can, if you do full-time students, again, the more that you're going to school, the more that you're going to get that additional clinical hours. So if you're part-time, you may have more. But upon graduation, 4,300 hours for part-time, for full-time if you're an APRN student with 1 year of work experience, and 6,500 hours if you're a part-time nurse practitioner or APRN student with 1 year of full-time work.
okay. So when just to clarify, when we talk 4,300 hours, 6,500 hours, we're talking about clinical hours in a hospital or clinical setting under the
Right.
supervision of a physician, making sure that you guys know what you're doing and you're getting the experience that you need, as if you were a intern or a resident or any other provider, licensed provider as such. Your exposure, your hours are very similar.
Mhm.
Okay.
Right. And that also the clinical experience can be with an APRN that's been in practice as well. So
let me just go, and I'm leading up to our call to action or our awareness piece. So you spend your money getting your baccalaureate program and you find an employer, and maybe there's some tuition reimbursement from your employer, but by and large, the days of 100% tuition reimbursement for a master's degree in nursing are long gone. All
right.
right. So give me a ballpark figure. How much does it cost to get a master's degree that terminates or ends in an NP? And then how much does it cost to sit for your certification exam?
For the education program, it really depends on where you go to school, but it can range anywhere from $40,000 to $60,000 up to $100,000. It depends. Nurse anesthetist program is the most expensive.
Right.
That's $300,000 to
Yeah.
get that education because you have to do it full time. There is no part time.
Right.
So as you're advancing in your degree, there is more preparation that's required, and it will cost more to get that. The certification exam is probably around $700 to take that to get your certification.
Just to be allowed to sit and torture yourself for the exam, you got to pay almost $1,000 for the privilege, right?
Right.
That said, That said, in order to qualify for financial assistance, the way the reimbursement or the loans are structured, as I understand them, for professions.
Hmm.
Okay.
Right.
And what I understand now is that the Department of Education, and most people don't realize this, we are not licensed by the Department of Health. We are licensed by the Department of Education. An LPN is licensed by the Department of Education, and RN is licensed by the Department of Education, as is a nurse practitioner. So the Department of Education has sent out recently, within the last year or so, notification that it wants to demote the profession of nursing to a non-professional status. The financial implications of that is that if that goes through, then nurses will not be able to get the student loans in the amounts that they need to become a nurse anesthetist or a a family practitioner. Please speak to that.
You're absolutely right. One of the things that the Department of Education did is they went back and in 1965, when this statute was in place, the nurse practitioner profession just was born. So there really wasn't this advanced role other than a clinical nurse specialist or the CRNA. And so when now they're talking about that professional degree, it really we've advanced a lot in our education and training. And so we really do need those advanced degrees. And sometimes these loans are the only way that nurses can go to school to get these advanced degrees if they get that financial support. So that becomes a real problem. And if we can't get the education and training, it's going to have a trickle down effect, because then we're not going to have the supply of nurse practitioners or certified registered nurse anesthetists to take care of us and fill the gaps. And nurse practitioners, our profession is growing. We're at 461,000 nurse practitioners, and that's continuing to grow. But this will definitely put a halt in a lot of people's plans to go on and get advanced degrees.
So at a time when we know the population and the multiple comorbidity needs of the population, the complex needs of the population is increasing exponentially every year. We also know that enrollment into medical school, specifically primary care, which is your family doctor, as opposed to a cardiologist, neurologist, or specialist, the primary care physician the enrollment is at an all-time low. All right. We are now the Department of Education is now proposing that we limit access to education loans. Nobody's going for free. We got to pay back the loans. They're limiting access to the education loans that are commensurate with being able to underwrite the education needed to maintain the level of practice we have now, let alone fill the gap that is needed. Am I correct in that?
Absolutely. So,
Okay.
so one of the things that's happening is the American Nurses Association has put together a petition to the Department of Education, pleading with them basically to, reconsider this and really rethink this decision to limit the loan status for advanced practice nurse roles, for example. And it's not just us, there are other professions that are affected by it as well. But for the nursing profession in particular, this is really going to have all those downstream effects that we don't anticipate until we're in that situation. So the petition itself is really a way for us to utilize our voices to get the message out that this is a matter that really needs attention. So the ANA has a petition, and American Association of Nurse Practitioners also has a petition if you go on their website as well. So it doesn't matter which one you pick, just sign up and get your voice heard.
Okay.
I just have some comments here. I mean,
Mhm.
I don't know, I guess because it is my show, I'm taking this really personally because I know I was just for a year ago a CDPAP caregiver worker being paid, and I saw that get cut off because of a lot of the similar legislation you're now talking about, as far as the way that they are looking at the nurse practitioner as kind of irrelevant, which I highly disagree with. But my question is, other than this call to action and this letter writing campaign, which everyone out there, I hope you do what you need to do to get whatever call to action is necessary because this is not a profession that needs to be downgraded. All right. And I'm being kind of angry about it. So forgive me if I'm out of line. But that being said, Lynn, isn't there any kind of also a call to action to possibly put the nursing profession under the Department of Health? Couldn't that happen? Or I guess I'm just not sure about how the whole regulations work.
Well, I think the whole point is that federally they're looking to cut as much as they can. And so it's going to be incumbent upon the states, if the federal government doesn't come forward, that the states might have to take this on themselves. I'm in Connecticut, so I can speak to that. There is a bill in Connecticut going through legislative channels right now to help offset some of the costs should this go through. So again, there will be opportunities beyond if this doesn't go through, but get your voice out there, get your voice heard, because this isn't a time for us to sit back and hope that somebody else is going to take the lead. We have to advocate for our profession.
Absolutely.
Right. So the website for all of this, for you to either log on and get more information, or to be able to access the petition that you can sign on to, is nursingworld.org, which is the website of the American Nurses Association enterprise. Do you know the one for the nurse practitioners, Lynn, offhand?
It's www.aanp.org.
Okay.
And the other thing is, get your family members to also sign this petition. It's not just for nurses, it's for all of our patients. It's for you, Frank. I'm glad that you're hopping mad over this. Because
I am.
Because I think once people actually find out what's happening to nurses in general, people are appalled to hear that all this is happening, and they're upset about it. So this is a way that they can help out too.
Right. And in lieu of that, they can call their local representative and they can voice their concerns that way, because it will be the local representatives that at some point will have to, if this indeed goes through, the local representatives will have to, mount the response and then have something overturned. You want to speak a little bit about what Connecticut is doing?
Right. So this legislative session, Connecticut has sponsored a bill that is actually going to put millions of dollars in a kitty for supporting nursing education. And that's going to be set aside in hopes that, the federal government will come to their senses, hopefully. I don't know if that's going to happen, but at least, this will be an opportunity for some monies to be set aside for nursing. And I don't know if people are aware, but medical funding is done through the Graduate Medical Education Fund, which is part of the CMS or Medicare, Medicaid program. And the hospitals get billions of dollars to train physicians. And nursing has been underfunded for decades. We don't get the funding. So when you think about, our profession growing, we need a lot of educators out there to train the next generation.
Right.
So this is another area where this bill is going to hamper that. So
Yes.
again, there's a lot of work to be done, but get your voice heard.
And I
Well,
really
Lynn,
think the
thank
hospital
you. I think-
systems also need to go ahead and sponsor if they can. But
Well,
all right, yes,
more
I
to
know
come
you're-
more to come
Yes.
next week, right, Frank?
Exactly. So everyone out there, probably it was just about the right time for me to get my blood pressure up on this issue, because it is pretty much saying that you need to stay tuned for the next episode on March 5th, right here on talkradio.nyc, and to see the results of this call to action that Lynn discussed. And I do agree with you and Lynn and Phyllis. This needs to be on a state-by-state basis, at least in the short term, and see what happens. I figure, the blue states will probably be more responsive to something like this, but that's just my opinion. All right, everybody, thanks for being here on this episode of Frank About Health. Thanks behind the scenes, Jesse, for engineering the show. Thanks again to both of you. I will see you both next week, and I will see you all next week right here on Frank About Health on talkradio.nyc. Signing off now. Have a good night.